Today I'm going to give the radiology perspective of what we see for JDM. So the first question is why to image? It's been said that physical exam cannot detect 20% of patients with muscle weakness. And MRI can detect the clinically occult sites of disease. We can assess the disease burden and the distribution. And we can monitor disease and treatment response. And also importantly, we can help direct the biopsy to increase the yield. So what imaging modalities? At Lurie Children's, MRI is the mainstay. It's a very powerful technique. Radiographs for calcinosis. Ultrasound and CT are not routinely used by us. People have mentioned CT for calcification. We don't typically do that at Lurie Children's. And calcification is easier to see on X-ray. Some people think MRI is better for everything, but MRI is mainly for the assessment of the edema, very sensitive for fluid. So again, why do we do MRI? We can evaluate the extent of the disease. Very, very sensitive for edema. So MRI picks up water, edema of the muscle, of the fascia, of the subcutaneous tissues. And as we saw before, if we don't know the exact muscle group that is involved, we could get a biopsy that seemed normal when there actually is disease. So it can help direct the biopsy to the site of the most active disease, especially if it's patchy, and I'll show multiple examples. So at Lurie Children's, we have a 12 to 24-minute protocol that depends on the patient's size. We don't give contrast. Some places do give contrast. When I read on the adult side, often we do give contrast. However, the edema often matches what you see on the post-contrast imaging. So it's pretty much the same thing, so we don't necessarily need it. Our main protocol is just the thighs, because obviously that's a very common site. Although later in the talk I'll get into some more advanced techniques. And what we're doing is a very short series. We're doing axial T1 and stir, and I'll show images of what that is, and coronal T1 and stir. So here is a stir image. So a stir image is basically one of MRI's best sequences. What it stands for is not important, but what it is a very highly sensitive T2 weighted sequence that has fat suppression. So what that means is that it can detect tiny bits of water. And the reason it's so sensitive is because we've taken the white signal from fat and we've made it dark. So it changes the grayscale of the imaging so that anything bright will be more apparent to the reader. So if you notice, the subcutaneous fat is gray, is dark on this image. If you just did a regular T2 weighted image and didn't change anything, fat would actually be white. So the fat in here is suppressed. And by the way, this is a normal MRI of the thighs. Muscle has this typical gray appearance. And you can see small white dots and little curvilinear white structures. These are just vessels, normal vessels in the muscles. In this area, we're looking at the quadriceps muscles, and we can see this black line. This is a tendon. And fascia, if it's normal, is often invisible. We don't even detect it. So when I show cases of fasciitis later, you'll see what that is. And in the center, obviously, is the femur, and the black is the cortex of the bone, and the center is the bone marrow space. How about a normal T1 weighted image? So on T1, again, we have the subcutaneous fat, but notice how it is white. It's very bright in signal on T1, so that's a normal appearance. Fatty tissues you can see in the bone marrow as well. That's normal. And you can also see fatty tissues along the intermuscular planes. So you can see surrounding the quadriceps muscle group, there's a little white fatty plane, and then we're separated by the posterior muscle compartments and the adductor compartments. Muscle, again, has sort of this grayish look, and when we'll show cases of advanced disease, fatty infiltration of muscle is very readily detectable in MRI because the new fat in the damaged muscle will have this bright signal. So that's what we look for when we're trying to diagnose atrophy and fatty infiltration. And again, tendons are black. Fascia is often not visible, as we said, even on T1 when it's normal. So these are coronal images, and this is normal as well. You can see here, this is the T1 on the left and the STIR on the right. And this is a typical set of images from one of our JDM protocols. And you can see that we have a really nice look. I link these side by side as I scroll. On the PAC station, I can assess the T1 and the T2 signal within a muscle. So if I see that there is edema in one muscle, I'll go straight to the T1 and see if there's also some atrophy or fatty infiltration of that same muscle group. And I can also look at the joint fluid, the bone marrow signal, and all of that at one time. So some general imaging characteristics. No surprise, the abnormalities on MRI reflect the areas of muscle weakness. The proximal muscles of the upper and lower limbs are affected, and it's often symmetric in distribution. So let's go over the MRI findings. So the main finding we're looking for is muscle edema. And I'll show pictures of that on the next slide. The other finding that was new to me when I started practice was subcutaneous edema. And so it's been thought to be associated with a more aggressive course and a potential precursor of the dystrophic calcifications that we've seen. So we look for that as well. Then we look for fasciitis, which I'll show images of. And we also then look for muscle atrophy and fatty infiltration for more of the chronic disease. And we have calcinosis as well, seen in 12 to 47%, and it can have the appearance of nodules or sheet-like. I'll show examples of both. Predilection sites, there are sites of trauma as well, elbows, knees, buttocks, flexor surfaces of the fingers, as we've heard. So this is an example of muscle edema, and it has a diffuse appearance. So if you remember the other side that was normal, these muscles are all a little bit too bright, a little bit too white in signal. But it involves every muscle group that you see on the image, from the pelvis to the adductor muscles, the quadriceps, all the way, all of the whole thigh, anterior, posterior compartments on the axial. And this is another pattern which is interesting. So this is patchy. And it's important to realize this is why we have to help our rheumatologists work very closely with them to tell them which muscle group, if they're going to biopsy, would give the highest yield. So in this case, if we biopsied a posterior compartment or this muscle immediately, we would get a negative. So I would tell someone to biopsy this vastus lateralis muscle here in the patient's right thigh because the area has the most edema. And then subcutaneous edema we talked about. And what it is, again, edema on MRI is this bright white signal. And so when you look at the subcutaneous fat over the hips, we can see this particular area of subcutaneous edema. And on the axial, this is just a diaper, so ignore this white thing in the center. But you can see here that there's this rind of T2 hyperintense signal, this edema, and the subcutaneous fat on both sides. So we try to mention that in our reports. And this is where you can really start seeing the fascia. So this is an MRI finding of fasciitis. Now this, of course, is not specific to JDM, and we just mention these in the reports, but what you can see is that the fascia, which not only will envelop the entire thigh, but also each individual muscle group. And so here you can see nicely that the white etching of the posterior thigh musculature, this is the edema within the fascia. And this is an interesting example, just showing that the anterior muscles, the quadriceps muscles, have undergone severe atrophy and fatty infiltration, whereas the posterior compartment is still maintained. And the imaging finding is that on T1, that gray muscle signal has been replaced by fat signal. So calcification is tricky on MRI. I think X-ray and CT are much better to detect calcification. What it would look like, just similar to bone cortex, which is black on MRI, you have this very, very dark signal. So this is an example of this nodular calcification on this pelvic MRI and thigh MRI that you see here in the buttock area, these globs of very dark signal. And this is actually the same patient on X-ray, just think it's a little easier to see these kind of nodular areas of calcification. And then this is an example of the sheet-like calcification in the thigh here. There's some other examples of nodular calcification in the soft tissues. This actually has sheet-like and nodular calcification on this picture. So some more advanced techniques, and I have to thank Dr. Ardalan, I don't know if he's here in the audience, but for pushing us to try to do more whole body MRI for JDM. And so we've had a few cases where we've been able to do this at Lurie. It requires imaging at multiple stations, and then there's stitching software you have to have, which can kind of stitch it together to show the pictures that I'll show here. Produces very cool pictures. And so the power of whole body MRI, as you can imagine, it can detect clinically asymptomatic sites of disease, assess the distribution and what's been termed the total inflammatory burden, again, patterns of patchy or diffuse, and to assess the disease activity. So these images are from a recent article from a rheumatology journal that Dr. Ardalan sent me as well. And what this shows is three different patterns. So on the left here, we have a normal patient, and we have a whole body MRI image from head to toe showing normal gray muscle signal. In the middle image, we have multiple patchy areas of muscle edema. And what's striking, and the article goes over it, is that there's a surprise that there's more distal involvement, which is not as clinically apparent as the proximal muscle weakness that we're detecting on MRI. And again, this is another example of diffuse muscle edema, so the slightly grayer look of all of the muscles everywhere. So it gives you a sense of the total body burden. In this study of this article, they looked at 41 patients with JDM and developed a scoring system based on the degree of inflammation on MRI, and they correlated whole body MRI to some of the clinical tests that we've heard today. So what were the findings? It showed the pattern of disease and estimated the total body disease burden, detected disease in muscle groups that were not detected clinically, for example, distally. The abnormalities in the subcutaneous and the myofascial areas correlated with higher degree of muscle inflammation, and it was able to show resolution of signal abnormality after treatment. And the MRI score correlated with muscle strength and other tests. So importantly, it was able to distinguish active from inactive JDM patients, and that it was more accurate than clinical for assessing disease remission. So I thought this was an interesting point, that patients with muscle damage might be mistaken for having active disease clinically because the muscle has just been chronically damaged. However, the MRI will show there's actually no edema signal. So in conclusion, MRI is highly sensitive to detect active disease in JDM patients. MRI can distinguish active and inactive disease. It can be used to monitor patients on treatment. And whole body MRI is a newer technique that can assess total body inflammatory burden and serves as a measure of disease activity. Thank you.
Now, I understand you don't use ultrasound here at Lurie Children's very much. Is there any promise, though, that ultrasound can, at some point, help us to evaluate disease activity and disease location and maybe do away with some of the cost of MRI?
Sure. I'm trying to build up a lot of the musculoskeletal ultrasound at Lurie currently. MRI is just very good at assessing muscle edema, better than ultrasound. Ultrasound can show edema, acute edema in muscles. And it also can show atrophy, and it has a particular imaging appearance. It's sort of the trees, not the forest. So you have your probe, and you're scanning one particular group. If you were going to scan, the whole body, it would take you all day. If you're going to do the thighs even, it would take a long time to scan it. If there's a particular muscle group you wanted to evaluate, then it certainly could look at that area. But it is tricky. I think it could be used, for sure, more. Could do it at the same time as the MRI and see if you are able to pick up, the abnormalities.
First of all, thank you so much.
Thanks for inviting me.
I had not met this young man before, so it's wonderful to welcome you, because there's a lot to do. And we have a study, I think we still have it, where we have an initial biopsy and then a needle biopsy of the same area on MRI. And we haven't really gone, I was waiting till the gene expression stuff got sensitive enough to be able to pick it up. But their ultrasound might be helpful, because you don't have to go through the whole, and for the smaller kids,
Sure.
You don't need the anesthesia.
Yes.
And so as the kids get bigger and can cooperate, it's much better. But we had this little group of about 25% that are 4 and under, and they wiggle. And then that's another problem.
Right. Definitely.
In addition to the expense.
Hi, Susan Shenoy, Seattle Children's Rheumatology. I have a couple patients that have extensive calcinosis involving their entire body, and I always struggle clinically as to how to quantify it. I can't possibly mark every site on my homunculus. Is there a way to radiologically quantify it, like with serial CTs or something like that?
You can do CT. For sure, we always try to give less radiation, try to not, do CT if we don't have to. Certainly CT can pick up the calcifications. You could do a skeletal survey, like we do with X-ray, multiple different body parts, and just kind of, you'll get a sense of how much calcification there is. I personally don't know of an actual, way to quantify. I basically just measure the areas, but if you just wanted to see where they are, skeletal survey would be one thought. A whole body CT you could do, but it seems like a little bit much. Although our CT, the dosing is getting lower and lower. Some of our CTs, if you're just looking for bony detail and calcification, it requires much less radiation than if you're looking for solid organ abnormalities. So for example, at Lurie Children's, our physicists tell me that we can do a pelvis CT which with only a tiny bit more radiation than a double pelvic X-ray. So, and extremities are even less sensitive to radiation. So there, you could, but.
I think the issue is, once you have calcification, does it matter how many different spots? That would take a long time to concentrate. I think the issue is what Maria Ibarra did, that we have finds with single slice CT, and maybe we can wake that up again. Can you make a difference? Can you alter the size of that calcification? And so if you have a target that you can look at, and granted, I don't know if different parts of the body behave differently, which is where your question would come in, makes the difference. But you're sitting next to somebody who might be able to tell you if you have the predisposition.
Hoping to collaborate with him.